Good day, friends and colleagues. Today I will be discussing our collective experience in food testing in the Philippines, which is the result of collaboration and hard work of many of our members for the past year as the COVID-19 pandemic unfolded. In late May 2020, the PSP held a Zoom meeting on how best pathologists can contribute to the pandemic response, seeing how disorganized the testing efforts were with proliferation of doubtful quality antibody testing, which added to the confusion in diagnosing SARS-CoV-2 infection. A position paper was issued as a result of this discussion in which we advocated the use of pool testing as a means to increase testing capacity, save on resources, reduce turnaround time, and to facilitate exit from community quarantine back to its normal economic and social activity. Here is the timeline. May 2020, the PSP comes up with a position paper to employ pool testing in asymptomatic populations. June 2020, the PSP presents proof of concept study to the Philippine Department of Health Laboratory Experts panel. It formulates a formal research proposal sponsored by the Philippine Center for Entrepreneurship Incorporated, or GoNegotia. In July 2020, the research proposal was presented to the Department of Science and Technology and Department of Science Technical Advisory Group, and a research application for 3 COVID-19 testing laboratories was done. In August 2020, statistical analysis was done after the physical efforts in the research. An investigator's discussion and analysis was done as well in a meeting at the PSP headquarters. In September 2020, the initial research findings were presented to CLEP, which recommended presentation to the DOH Executive Committee, and similarly, it was presented to the Philippine Interagency Task Force for Emerging Diseases, with formulation of guidance document on how to perform pool testing. In October 2020, a formal research paper was submitted to the Health Technology Assessment Council, and training modules on specimen collection and laboratory staff training on pool testing were formulated. A total of 15 laboratories all over the Philippines were trained at that point in time. In November 2020, the DOH issued guidelines for pool testing released in December 23, 2020. This is the research that was published in the Philippine Journal of Pathology in January 2021. For those who would like to know the details of this research, you can read it in the January 2021 PJP online. I will be briefly summarizing the results of the paper and give a brief discussion, for there's so much more to talk about later. A summary of results for experiment 1. Overall, pooling size of 1:5 dilution has the least drop in sensitivity and smallest mean change in CT values for low positive samples. For experiment 2, we had a study population of 440 supermarket workers with a prevalence of 3%. Accuracy was 98% in all pool sizes. Test savings ranged from 70% to 82%. Turnaround time decreased from 2 days maximum to 1.0 days for pools of 5, increasing to 1.22 days for pools of 10 and 1.46 days for pools of 20. Overall, pools of 5 are recommended for faster turnaround time and comparable savings with the least drop in sensitivity. This table illustrates the average savings per batches of 100 specimens calculated using 10,000 simulations. This is courtesy of Dr. Mark Am. These are our conclusions. Pooling is a feasible strategy to further increase testing capacity and decrease costs while keeping accuracy at within acceptable levels. A two-stage Dorfman 5 pooling uh, sorry,
Go.
a two-stage Dorfman 5 pooling strategy appears to be the best method because it has the highest overall accuracy while still achieving acceptable test savings and turnaround time. Pooling of nasopharyngeal and oropharyngeal swab samples prior to qRT-PCR testing may be considered by select molecular diagnostic laboratories to further increase testing capacity and at the same time reduce the cost of testing as a feasible means of adapting more relaxed quarantine schemes. The use of pool testing, with its slight loss of sensitivity but large test savings and applicability to the asymptomatic population, lends it well to use for frequent testing in order to catch highly infectious persons in a timely manner and avoid further spread of infection. We address all the phases of clinical laboratory testing to ensure that the pool method will be successful. For the pre-analytical phase, sample collection must be more organized to avoid rejected samples and delays in specimen processing in the laboratory. In the analytical phase, guidelines must be in place for uniform practices, ensuring accuracy and minimizing errors. For the post-analytical phase, reporting should not be too cumbersome and time-consuming, or else what is gained in speed of testing will be lost in the releasing of results. Now the current situation is different. We now have over 200 labs currently testing for SARS-CoV-2. The PSP was instrumental in training many pathologists in molecular pathology, enabling them to supervise these labs and release SARS-CoV-2 results in a timely manner. We had devised a training module for organized swabbing, packaging, and transport. Using a whole day workshop on biosafety guidelines for COVID-19, specimen collection, packaging, and transport, demo and return demo on donning and doffing PPE, demo and return demo on swabbing, demo and return demo on packaging and transport, as well as pre-test and post-test. We had actual trainings done for pathologists and medical technologists on the pooling procedure with work instructions, including accessioning, pooling procedures, quality control measures, the convolution or individual testing of positive pools, results analysis, results releasing, and distribution of data collection templates, SOPs, and validation procedures. These are the contents of the training packet for testing labs: specimen receiving, testing, interpretation, deconvolution, data management, and standardized training on specimen collection, packaging, and transport. We are institutionalizing the pool testing training by means of PCMC certification process for trainees and specimen collection, application to the PRC for CPD units, support for trainings and mentoring for government labs, and the RITM verification process. At this point in time, we have 52 RT-PCR labs trained, of which 15 have been RITM certified by passing the verification procedure, and 37 labs are undergoing the verification process. This is the distribution of the 15 RITM certified labs for pool testing as of March 29, 2021. We undertook pilot projects to illustrate the utility of pool testing. Our target populations were asymptomatic individuals in high contact areas or occupations. In the public area, these were the public market vendors and tricycle drivers, in the office area, bank office employees, and in the residential area, security guards, barangay tanod, family drivers, and house help. The positivity rate in the exclusive village staff and employees turned out to be 8%, with a total number of specimens run of 116, out of which 9 were positive. And this translated into a 46% test savings. The positivity rate for bank employees was lower at 1.4%, with 8 testing positive out of 554. Test savings were maximum at 73% with the bank employees. For the market vendors and tricycle drivers, we had the 17% positivity rate, since 597 tested positive out of 3,428. For only a test savings of 21%. While the savings in this group was rather small compared to the other groups, what would matter most is that the number of positive individuals identified and isolated to prevent further spread is very significant, since if they were not identified and with R naught of 2, there would have been over 1,000 additional infections, plus the secondary contact infections would have led to an outbreak. Additionally, we did pilot projects on domestic tourists in conjunction with the Department of Tourism. Out of 14,880 negative cases, we had a positivity rate of 2.24%. And this translated into a 67.63% savings. What were the lessons learned from these pilot projects? Number 1, asymptomatic cases present in the frontline workers may be super spreaders if undetected.
Go.
What were the lessons learned with these pilot projects? Number 1, asymptomatic cases present in the frontline workers may be super spreaders if undetected. 2, different subpopulations have different positivity rates. Market vendors have higher rates than tricycle drivers, than village employees, than bank employees. 3, higher positivity rates in lower socioeconomic sectors are observed, explanations of which may be the crowding, poor sanitation, and less awareness of public health measures. 4, test savings vary with positivity rate. Low positivity equals bigger savings. 5, turnaround times are similar to that of individual testing. In March 2021, the Philippine Society of Pathologists issued another statement on the current pandemic situation with the topic of strategic testing to assist in managing local COVID-19 outbreaks. When positivity rates started increasing, the pooled testing group once again met and with this issued this position paper. However, it took 3 weeks before the NTF took notice upon intercession of Dr. Chris Abisamis. We cited several articles to bolster our arguments, and these are the pool testing used to curb outbreaks in South Korea and China. In the South Korean situation, they stated that it is a way of substantially lowering the cost and time needed for testing while maintaining testing accuracy. This is another article that states using pool testing for vulnerable groups, and that it states that the pool testing will be mainly used for COVID-19 monitoring in high-risk groups without symptoms, not for COVID-19 confirmation. So there is no need to worry about the inaccuracy of patient care. Primary intent here is to identify a patient in hidden communities that will contribute to the prevention of the disease. Similarly, in China, they used pool testing to test a majority of the city of Wuhan's population, reaching roughly 10 million people in just over 2 weeks. Again, this illustrates the utility of pool testing in response to a cluster of cases. The European Commission asked the European Centre for Disease Prevention and Control to organize a webinar where countries describe their approaches and experience with regards to mass testing. And in addition, the EDC was requested to gather all available information on mass/universal testing practices from European and non-European countries and provide a scientific opinion on this intervention. So, targeted testing of populations in specific settings. Testing in these settings has sometimes been described as occurring in a response to a cluster of cases reported in that group or setting, or carried out to protect vulnerable populations. The current surge in COVID-19 cases have various reasons, which are either that it is driven by variants, relaxation of public health measures, wider opening of the economy, or vaccine optimism. But whichever may be the case, we need to control this surge. While there were granular lockdowns in certain LGUs, limited testing and contact tracing will not address the rapid spread of the virus. In fact, it may exacerbate the spread since families are locked in together and it will spread rapidly from family member to family member. So we need a rapid identification of asymptomatic cases which are driving the spread, in addition to aggressive contact tracing and isolation quarantine to suppress the outbreaks. Last year's lockdown did not achieve control of the epidemic due to the lack of mass testing, which was understandable then due to the too few molecular labs in existence. Hence, lack of containment with continuing community transmission upon relaxation of measures to allow economic activity to resume. So we have a proposal here to address the rapid increase in cases threatening to overwhelm our health system. Individual testing continues for close contacts and asymptomatic persons who are expected to have higher positivity rates based on probabilities. Pool testing will be employed on the rest of the asymptomatic persons in the community within the lockdown area. To achieve economy of scale, since the likelihood of testing positive will be lower once the close contacts are eliminated. This addresses the concern that cases will be missed if pool testing is done in high positivity populations. It will immediately remove the identified positive cases from the community to prevent further spread. With this proposed scheme, testing is conducted within a 10-day period, after which positive cases will have been identified and isolated. The remainder of the community that has undergone pool testing can be released to a more relaxed scheme and resume economic activities with strict observance of minimum public health standards. It will alleviate economic suffering by freeing those identified as virus negative to work. Periodic surveillance screening through pool testing will prevent further outbreaks from happening again and again. This is the algorithm we have devised for this purpose. It may be complicated, but it simply boils down to identifying individual close contacts and doing individual RT-PCR testing on them. And for those who test positive, they will follow the same isolate and contact tracing procedures, whereas those who test RT-PCR negative will quarantine with the rest of the community for 5 days, after which all of them will now undergo symptom screening, and symptomatic cases will once again undergo individual testing. Asymptomatic persons will now undergo pool testing, and those who are RT-PCR negative can now be released to general community quarantine, while those who are positive will again be isolated and contact traced. So this actually adheres to the different memoranda that the DOH issued with regards to contact tracing and pool testing. What will it require? Close coordination of LGU City Health Office with the pool testing lab in conducting organized swabbing activities, transport of samples, and reporting of results. Funding of pool testing with provision of test kits and reimbursement of operating costs for the molecular labs. Aggressive contact tracing to identify close contacts, and provision of isolation and quarantine facilities. This is the rationale for pool testing in local outbreaks. A regimen of regular testing works as a sort of COVID-19 filter by identifying, isolating, and thus filtering out currently infected persons, including those who are asymptomatic. Measuring the sensitivity of a testing regimen or filter requires us to consider a test in context, how often it's used, to whom it's applied, when in the course of an infection it works, and whether the results are returned in time to prevent spread. This is from an article of Mina et al. In the New England Journal of Medicine, which perfectly encapsulates this concept of a trade-off on sensitivity with the benefits of a non-clinical regimen of testing, which applies perfectly well for pool testing. To illustrate, these are the city values of asymptomatic positives in the Makati LGU with the 13% possible super spreaders out of a total of these numbers. 77 had city values of less than 30, which may be considered as high viral load. And these are the persons who will be driving the spread of the virus in the community. We propose pooled RT-PCR testing as a tool to manage future pandemics, to rapidly test a defined population under lockdown to contain the spread of a virus in addition to closing borders and other public health measures. Had we done this early in the pandemic last year, we could have halted or prevented more spread of the virus. Our contribution marks a significant milestone in our society's history. It is not only a game changer in itself, but the first worldwide. Though pool testing has been done earlier in different countries, no other country has made an effort to systematize and conduct pool testing on a comprehensive basis such as ours. This complete package of pool testing will stand as a testament to the hard work, dedication, and perseverance of its members who believe they can make a difference. Our pool testing process will not only make a difference in our current situation, but I believe it is a lasting contribution to the Philippines, if not the whole world, that will make it useful in response to future pandemics. And we all know in our hearts and minds the COVID-19 pandemic will not be the last, though I hope the next one will not be in my lifetime. To my fellow pathologists, I salute and thank you for your courage, determination, and fortitude in undertaking this journey, and in the process prove to ourselves we have the capacity to lead and effect change, eventually in recognition of the Philippine Society of Pathologists Incorporated as a leader in the medical field. I would like to acknowledge the following: the Philippine Council for Entrepreneurship or Go Negosyo, under the leadership of Joey Concepcion and Jopin Romero, the Honorable Congresswoman Janet Garin of Iloilo, former Secretary of Health and Go Negosyo Chief Implementer for SARS-CoV-2 RT-PCR testing, Dr. Julius Lecciones, Executive Director of the Philippine Children's Medical Center, Dr. Criselda Abisamis, Go Negosyo Advisor, research co-investigators, Socorro Yanez, Bernadette Spirito, Agnes Barrientos, who braved the virus by engaging the recruitment of research subjects amidst the pandemic. Our PSP President, Dr. Robert Padua, and Dr. Amado Tandoc, editor of the Philippine Journal of Pathology, co-investigator for Experiment 1, and Chief Laboratory Research Division of the Research Institute for Tropical Medicine. Hats off to you, ladies and gentlemen. Lastly, to my beloved, hardworking, and totally dedicated PCMC COVID-19 testing laboratory staff, a million thanks. I owe you. Thank you very much, ladies and gentlemen.